good afternoon. Welcome to Grand Rounds. Today, I have the pleasure of introducing Dr. Kyle Ulveling. He attended medical school at Creighton, where he stayed to do his internal medicine residency, his cardiology fellowship, and he is board certified in internal medicine, cardiology, echocardiography, nuclear cardiology. And he has very kindly accepted our invitation today to provide us with a review of preoperative cardiovascular evaluation. And please join me in welcoming Dr. Ulveling.
Thank you. All right, so the outline for our talk this afternoon, we will discuss surgical risk stratification, we'll discuss patient risk stratification, we'll discuss when appropriate perioperative cardiovascular testing, perioperative medication management, and then I'll open the floor to any questions or comments from in-person or virtual attendees. The big focus, though, is going to be on where the red box is, so to focus on the nuts and bolts of preoperative cardiovascular evaluation. I appreciate the introduction. Basically, I spent my entire life in either Carroll or Omaha until last year. I finished my cardiovascular training in 2013 and joined Iowa Heart at that point. I was in our Carroll Iowa Heart Center office until 2024 when I joined our Ames and Ankeny offices, and I moved my hospital responsibilities from St. Anthony and Carroll over to Mary Greeley. So I've been here for the last year and can absolutely say I've been enjoying myself immensely. The patients are wonderful, and my colleagues in the hospital have been wonderful to work with. All right, so just to start off, in the United States, what's the overall incidence of perioperative myocardial infarction? So this is reasonably recent data going back 10 years ago, and this is covering over 3.8 million surgeries. So we know that the risk of perioperative myocardial infarction is low, but really how low? So I've got some choices. This is just not going to be a show of hands. There's no survey, but just kind of a mental exercise. The answer for in the United States in general is less than 1%. Technically, it's a little over 1/3 of 1% is the incidence of perioperative myocardial infarction. Now, that does change when you go away from the general population and you start talking about patients with or without risk factors. So if a patient has one risk factor for cardiovascular disease, it goes up slightly to a little over 0.4%. If they have two risk factors, 0.8. If they have three risk factors, it goes just over 1% incidence. General population, just over 1/3 of 1% perioperative myocardial infarction. All right, so this is the most up-to-date algorithm from the American College of Cardiology and American Heart Association for perioperative risk stratification and testing. In truth, it is not a whole lot different than the prior major update, which was in 2014. They use a little different terminology. They've introduced one new level of perioperative decision-making on testing, but it isn't a whole lot different than the last major update just over 10 years ago. So we're going to start with surgical risk stratification. So what is the risk of ischemic complications from the surgery, regardless of who the patient is going through the surgery? So the two largest factors that determine perioperative myocardial infarction risk are the depth and length of sedation/anesthesia and the potential for blood loss. There's a way to calculate it. There's more than one way to calculate what the risk is of surgery, specifically the major adverse cardiac event rate. And that's the most formal method to do. Now, the nice thing is this has been done for multiple surgeries for multiple decades. In general, in the 2024 guidelines, if a surgery has a major adverse cardiac event rate of less than 1%, that's considered a low-risk surgery. If they have a MACE rate equal to or greater than 1%, that is an elevated risk surgery. Now, that's a little different terminology than what we used to use previously. What we used to use previously for MACE greater than or equal to 1% is we would break that out into a intermediate risk surgery and a high risk surgery because the decision algorithm was a little different for those two. We'll go into that more. The decision algorithm really hasn't changed, just the verbiage. So in 2025, in clinic, in the hospital, I don't think anybody's expected to frequently use a MACE calculator for routine surgeries. Those MACE events are well established, but it is useful for novel or uncommon invasive procedures. All right, so for commonly performed invasive procedures, this has been well established, and here is a very useful table that has been reproduced multiple times. This one is from 2022, but it lists many of the surgeries that we would encounter at Mary Greeley Medical Center on a routine basis. So just some general groups of what's considered a low-risk surgery based on their adverse cardiac event rate. So non-total joint orthopedic surgery, carpal tunnel, hardware repair of foot and ankle, things like that. Those would be considered low-risk surgeries. Urological, specifically TURP, is a low-risk surgery. Ophthalmologic. And now, VATS is one of those things where this is where I'm okay with all of us having to discuss this on a case-by-case basis on the patients, because VATS can be low risk, VATS can be high risk, depending on what else you're doing with VATS surgery. Intermediate risk, total joint replacement orthopedic surgery, intra-abdominal surgery. This is where carotids are pulled out of vascular surgery. Most other major vascular surgery is considered a high-risk surgery because of the potential for bleeding. Carotids are considered intermediate risk. That's not novel. That goes back to 2014. And then high-risk surgeries. These are all things that are much less common, but pretty well established because of their bleeding risk, and they're also very long surgeries under deep sedation and or anesthesia. So open heart surgery, non-carotid major abdominal surgery, vascular surgery, including loss of limb, things like that. All right, now we're gonna move on to the patient. So what is the ischemic risk of the patient regardless of what surgery they're going under? So the first decision point of the 2024 guidelines are, is the patient stable or unstable? And now this is where they have very specific criteria for an unstable patient. Clinically, we would use any patient who's clinically worsening to be described as unstable. That's not for perioperative guidelines, for perioperative management. According to the 2024 guidelines, an unstable patient is one experiencing acute coronary syndrome, decompensated heart failure, or unstable arrhythmias. Now, in real life, does worsening shortness of breath possibly represent decompensated heart failure? Yeah, it does. Does new or worsening chest pain possibly represent acute coronary syndrome? Yes, it possibly does, but it doesn't mean that all chest pain is acute coronary syndrome, nor is all shortness of breath automatically decompensated heart failure. So if a person does have a clinically worsening symptom that has a clear other etiology, we wouldn't automatically say that that patient is unstable by the cardiac preoperative guidelines. So an unstable patient, this is the first stop at this point of the algorithm. An unstable patient would be an indication for urgent preoperative management and multidisciplinary discussion. It may not mean that you postpone the surgery for outpatient testing or postpone the surgery for inpatient urgent testing, but it might mean you make sure of the disposition of the patient. Outpatient surgical center versus inpatient hospital versus critical access hospital versus tertiary care hospital, all of those decision-making. And this is where the multidisciplinary team concept absolutely has a role on multiple levels of the preoperative evaluation. All right, so a low-risk patient would be a clinically stable patient without obstructive coronary disease, without known LV dysfunction, and without severe valve disease. These are a lot of our patients. So a patient who had an abnormal stress test 5 years ago, who had an angiogram or a coronary CTA 5 years ago that showed mild non-obstructive disease, that patient would still be a low-risk patient if clinically stable. We will get to their functional capacity later on, but as far as at this point in the decision-making, they're a low-risk patient. This is where the terminology again changed between 2014 and 2024. In 2024, they wouldn't refer to this as a low-risk patient. They'd refer to this as a patient with no risk modifiers. Maybe it's because I'm of a certain age, I still, in my documentation, refer to this patient as a low-risk patient. A moderate risk patient, or in the 2024 guidelines, a patient with risk modifiers present, is a clinically stable heart patient. So a patient with known obstructive disease, with known prior revascularization, a patient with known prior cardiomyopathy, they may not be recovered cardiomyopathy, they may be stable LV dysfunction. They may have a stable regurgitant valve. They may have a prior device. A pacemaker or defibrillator that is a risk modifier that does put them in the older terminology as a moderate risk patient if they have a device. So these are stable heart patients, or patients with a risk modifier. High-risk patients. So these are clinically unstable patients from the prior decision point. A patient with a prior recent revascularization that is going to have surgery because of a new acute event. A patient with recent open heart surgery, typically within 6 months, for sure within 3 months. Or a patient with prior known severe stenotic valve disease. While regurgitant valve disease can make distribution of sedatives and anesthesia agents more complicated for the case. It is of much less ischemic risk than a severely stenotic valve is for the case. So in the 2024 guidelines, they don't break out low, moderate, and high-risk patient. It's either risk modifiers absent or present, and then once you go to risk modifiers present, then there's more decision-making. But it doesn't change the overall what we've been doing, even going step by step. All right, so this is this point. So if you have a low calculated risk surgery, if you have a patient without risk modifiers, which would be a low-risk patient undergoing a low-risk surgery, proceed to surgery. You do not stop for an evaluation of functional capacity. I absolutely will put the functional capacity on every pre-op I do, because I'm expecting to get a call another month or two later saying, hey, we also need to do this, this, or this. Will your pre-op recommendations still be valid, or do you need to reevaluate the patient? But for a low-risk patient undergoing a low-risk surgery, even if they do not have a good functional capacity, they still could proceed to surgery without automatic pre-procedure testing. All right. Now, what if you don't have a low-risk patient undergoing a low-risk surgery? So in this part of this is that same 2024 algorithm broke down and zoomed in a little bit. What if you have a risk modifier present? So I'm trying to use my mouse so that people in virtual attendance can see at the top center of this graphic, elevated calculated risk, which means we're no longer a low-risk surgery. This could be an intermediate or high-risk surgery, and no risk modifiers. So this is a intermediate or high-risk surgery with a low-risk patient. Now we start talking about medical management. Now we start talking about functional capacity. So as soon as you no longer have a low-risk patient undergoing a low-risk surgery, that's when you start using the functional capacity as part of your discrimination. So METs. And my standard terminology has always been this patient does surpass the 4 METs threshold. This patient does not clearly surpass the 4 METs threshold. Sometimes I'll be honest, it is unclear if this patient surpasses the 4 METs episode. They're trying to tell me info, but I just can't feel comfortable that it's a strict yes or no, and that's what I'd say the surgical team, the inpatient medical team, and the anesthesia team is asking me to do, is try to come down on one side or the other of the fence. So if they cannot clearly meet or surpass the 4 METs level, that's when you would go down on this graphic. That's when you're not done yet. That's when we keep talking about peri-procedure management. So, moderate risk patient or moderate risk surgery, assessment of functional capacity. All right. So, metabolic equivalence, well established for 30 plus years as far as an objective assessment of the patient's ability to handle cardiovascular stress. So this is a 2023 graphic. It is absolutely unchanged. In fact, those might be 1989 illustrations on the left part of the graphic, but these calculations of METs still hold. So for METs, can you do gardening work like raking leaves, weeding, pushing a lawnmower, sexual relations? Can you bowl? Can you play doubles tennis? And then obviously if you can do much more athletic individual things, can you play pickup basketball? Can you play singles tennis? But the common ones we use, can you climb a flight of stairs? Can you walk up a hill? Calculates out at 5.5 METs. So can you walk more than 2 blocks without stopping? Can you walk up a flight or 2 of stairs without stopping? I honestly try not to introduce those phrases. I try to start with what is the most consistent exercise you do? And if the answer is none, what is the most consistent activity you do? Do you have a flight of steps in your home? Do you have to go down in the basement for laundry? All of those kind of things. And if they say, no, I absolutely don't do any of those things, they do not pass 4 METs. And if they do, then they do. So if a patient is undergoing an intermediate risk surgery, if the patient is a moderate risk patient and they can meet or surpass 4 METs, there is no indication for preoperative testing, proceed to surgery. And the opposite is also true with a large caveat, if it will affect peri-procedure management. And this is probably something that is being emphasized more in 2024 than it was in 2014. So if a patient absolutely needs to go through surgery, it is okay to say they are a moderate risk patient. It is okay to say that they're undergoing an intermediate risk surgery. It is okay to say that they do not surpass 4 METs. We are proceeding to surgery due to urgent complications of delaying, and that will affect your peri-procedure management, where you're going to do the surgery and postoperative follow-up, including inpatient postoperative follow-up. All right, high-risk patient or high-risk surgery, again, even if they can surpass it, this is where if they can surpass 4 METs, you may still consider doing testing. If they're going to have a major vascular surgery and they've never, ever had a cardiovascular workup before, many vascular surgery groups will request at least some initial peri-procedure testing for non-urgent surgery. So that's where I would just leave in there that if it's a high-risk patient or a high-risk surgery, you consider it. All right, now this is one of the new things. A new decision point was added to the 2024 guidelines. So when we would have one of those points where they are undergoing an intermediate risk surgery, they do not surpass 4 METs. Prior to 2024 guidelines, that would mean some form of ischemic testing. In the 2024 guidelines, you have the option of checking a high sensitivity troponin and a pro-BNP. And if those values are normal, you can consider proceeding straight to surgery after those values. I will say in my experience in central Iowa and in west central Iowa, this is not done routinely. I think all of us who have experience with the prior generation of troponin I and the current high sensitivity troponins know that we've lost some of our discrimination on the low end of non-ischemic troponin elevation like we used to with the prior generation of troponin I's. So it is absolutely got an evidence basis in the guidelines. And I would just say if that's a good, useful tool for anybody listening, I would just document and just put in according to the guidelines. They have a normal troponin, they have a normal pro-BNP. For that reason, we have no further testing indicated. This is also a team sport. It is not just the person doing the preoperative evaluation, it's the surgical team, it's the inpatient medical team, it's the anesthesia providing team. So putting one line in a chart doesn't end the discussion. I would say that if it's a patient that may look like somebody that you might have tested in the past, talk with it over with your teams. All right, so that's the text of what I just said. All right, so now we've moved on from the surgical risk stratification. We've moved on from the patient risk stratification. Now, perioperative medical management. All right, so these are the classes that I've devoted time for today, which are antithrombotics, antiarrhythmics, coronary artery disease or ischemic-related medications, antihypertensives, and then GLP-1s, because both for the cardiovascular indications and because of their appropriately frequent use for weight loss, we've encountered them quite a bit over the last few years. All right, antithrombotics, warfarin, this is no change, this is decades, held 5 to 7 days prior to procedure based on INR. A DOAC, a direct oral anticoagulant. So if it is a 10A inhibitor, such as apixaban Eliquis or rivaroxaban Xarelto, hold 2 days prior to the procedure. If it's a direct thrombin inhibitor, dabigatran Pradaxa, hold 2 to 4 days prior to the procedure, depending on the pre-procedure GFR. This is just where when you use a lot of these drugs, you know which ones, Eliquis we use creatinine, Xarelto and dabigatran we use GFR for dosing and for holding parameters. With the DOAC, as of August of 2025, there are still no automatic bridging guidelines for a DOAC. That does not mean that on a case-by-case basis with a patient's unique past history that you don't discuss it. You may do it, you will document why you're doing it, even though it's not in the normal indications. There is nothing wrong with that on a case-by-case basis. I would just say document it. All right, moving on from DOACs to antiplatelets. So clopidogrel Plavix, prasugrel Effient, ticagrelor Brilinta. And any of you who read cardiovascular journals, prasugrel's, man, that's a drug that went generic apparently 10 years too soon because whenever they present more data on it in the last 10 years, even though it's been generic forever, it actually is as good or better than many things. So even though that might not be a drug that we have seen a lot of, we might be seeing more prasugrel going forward. So for all 3 of these antiplatelet agents, hold 5 to 7 days prior to the procedure. I can tell you in my practice for patients who aren't on an extended, they had 4 stents at once, so they're on indefinite dual antiplatelet therapy. They're on the low dose of ticagrelor Brilinta long term, or they're just kept on clopidogrel 75 long term. For those patients, the ones who are within 10 months of their coronary intervention, they weren't an MI, Those I say hold 5 days. The ones that are longer, I hold 7 days. And then honestly, if any of us who do perioperative evaluations know, there are some neurosurgical and there are some anesthesia, pain-related, specialty-specific guidelines that have them hold them longer. And I tell the patients this is not a conflict. I'll present to you what the cardiac guidelines are, and I will put in my note to your providers. If the patient needs to hold their antiplatelet longer than this based on anesthesia's recommendations or based on neurosurgery's recommendations, I'll defer to their specialty management. It's not a conflict. It is not my job to tell a neurosurgeon how to properly do their surgery. It's my job to help. All right, aspirin. Now, this is something where, as opposed to 2014, many more routine surgeries can now be safely done and have evidence to be safely done on aspirin 81. So total joint replacements, which used to, I would say, very, very rarely be done on aspirin, are now much more frequently done on aspirin, which means non-total joint replacement surgeries are much, much more frequently able to be done on aspirin than without. If it is still required to hold due to the bleeding risk of the surgery 5 to 7 days prior. There is a little bit more evidence for aspirin to be held 7 and clopidogrel 5, but by the guidelines, both of them are still 5 to 7 days. Antithrombotics restart. So I can tell you my standard language in my preoperative notes are to hold X agent for X number of days and then to restart as soon as hemostasis is achieved, restart as soon as possible by their surgical provider, because we don't know what's going to happen on postoperative day 0. That is up to their surgical team and inpatient team. By guidelines, the expectation is they will be restarted 1 to 2 days post-procedure. So when I do have a patient who, let's say, is a has a history of prior thrombophilia, they may not be hematology managed. Let's say they have a patient who's had prior postoperative complications, thrombotic complications or ischemic complications. I will put a line in saying if their enteral therapy is not able to be restarted 1 to 2 days post-procedure, strongly consider parenteral therapy or multidisciplinary conversation. Just saying, let us help, but don't necessarily have it be 5 days post-op and we haven't restarted anything without a discussion or an alternative agent. All right. Antiarrhythmics. Very simple. As long as PO access is going to be available perioperatively and postoperatively, continue the antiarrhythmics. That's not a change. That's rather straightforward. If parenteral access is unlikely to be available perioperatively and postoperatively, multidisciplinary team approach. We are absolutely happy to help as your cardiology providers. If it's a beta blocker or calcium channel blocker that's being used for atrial fibrillation and the hospitalist team or their primary care team feels comfortable with, but just absolutely, there's alternatives to oral agents that we can offer. All right, coronary artery disease related medications or ischemic related medications. The best way we can phrase it is holding beta blockers and statins for patients who have been on them consistently increases their perioperative risk. We should not automatically start either agent just for the sake of surgery, with one little caveat. If it's a high-risk patient whose surgery is going to be delayed by 10 days to 2 weeks and you're not able to put them through testing, it's a very unique circumstance, but there is evidence to start a beta blocker and statin in a previously novel patient for a high-risk surgery who you can't do testing on to further discriminate their risk. That's a pretty rare thing. But the gist is, don't hold these agents. Continue beta blockers and statins perioperatively to decrease perioperative risk. And then this is new. This is different from 2024 from 2014. ACE inhibitors and ARBs used to be routinely, that was just a very easy, take your metoprolol tartrate, hold your lisinopril. That was a very common preoperative order. ACE inhibitors and ARBs can typically be safely continued perioperatively unless their blood pressures are low normal going in. So I can tell you I do it on a case-by-case basis. If they're on lisinopril for hypertension and their blood pressure at their preoperative appointment with me is in the 1-teens, then I ask them, do you take it in the morning or evening? And if you take it in the morning, hold it. They can give it to you late in recovery that day if they need to. If they're on it for an EF of 20%, I try to throw wrenches into the system as little as possible. So if their blood pressure is above 110 and they've got an EF of 30 or below, I typically say I would continue it perioperatively unless hypotension becomes an issue. And then other antihypertensives that are not directly ischemic or coronary artery disease medications, diuretics, thiazide diuretics, alpha agonists, vasodilators. You can typically hold them the morning of the procedure. If they're nighttime medicines, they can typically be continued. If they are morning medicines, they can typically be held just that day. They can be administered later in the day if needed, or the next day. It's not that they're automatically bad, it's that there's no reason to introduce extra hypotension, as even 24-hour sustained medicines aren't a flat line of pharmacokinetics. They do have a peak within a few hours after dosing. It'd be nice not to have that peak when they're also inducing anesthesia and sedation. All right, GLP-1 agonists. So it is pretty standard at almost every facility that I've encountered in the last 4 years that GLP-1 agonists are held 1 week prior to procedure, and it is first and foremost to allow GI motility to normalize. There's multiple other indications why it's held for 1 week. Now, we use different forms of agents, as Lilly possibly introduces an oral, these might all change. All right, so in summary, separate unstable symptoms from symptoms with known etiology. Low-risk patients undergoing low-risk surgeries, functional capacity is not automatically a discriminator. Obtain pre-procedure testing only if the result will affect peri-procedural planning. And then always, always, always a multidisciplinary approach for less typical cases. This is just a line that my partners politely asked me to put in. A prior cardiology evaluation does not make the patient a cardiology patient for life. If the last time we saw them was 4 years ago for a normal pre-op, that does not mean that they're a heart patient that has to automatically undergo a heart pre-op again because they had one 4 years ago. That being said, that was a favor to my partners. We absolutely are willing to help at any point. I do a full-time preoperative clinic for the Metro at least once a month. I enjoy doing them. But I would just say that all of us have a role to properly send patients, because if a patient really had no indication for a pre-op and their elective surgery was delayed, we all know that Mary Greeley is doing a fantastic job of facilitating surgeries on what we would consider close to normal basis, and that is not true at every facility in central Iowa. Let's not unnecessarily delay stuff if we don't have to. Before I turn it over to questions and comments, perioperative testing. So in the guidelines for ischemic testing, they always jump to typically vasodilator stress testing, because they're assuming if a patient can do a treadmill, they meet 4 METs. So that's why you don't see treadmill testing very much in any of the guidelines, is because they think those are 2 separate things. Not every patient undergoing perioperative testing is only because of ischemic testing. Sometimes it's because they've had a history of asymptomatic sinus bradycardia and you're trying to test their chronotropic evaluation. That's perfectly valid and reasonable. We have all seen patients that we've had to do a temporary pacemaker on. They don't meet criteria for a permanent, but we also don't want to make it a very rough surgery for the anesthesia provider and surgeon and patient. Even though the guidelines really focus on vasodilator stress testing when they talk about testing echoes for new harsh murmurs, suspicion of severe aortic stenosis, Holter monitors for bradyarrhythmias previously undiagnosed. A right bundle branch block is not automatically pathologic. That does not automatically require testing. Now, if they were sent to us for a right bundle branch block on EKG, but it turns out they've actually been having much worsening dyspnea and they don't suppress 4 METs, you might not be doing the testing for the right bundle. You might be doing the testing for worsening shortness of breath. But what I would do as a plea for myself is, if I start telling anybody who's calling me that you're calling me too much, then you're calling me too much. Otherwise, you guys are always open to call and ask questions. If it's just, hey, is this really something or not? We are happy to take those. We're happy to take those epic messages, things like that. So I would turn it over to whatever you guys normally do, whether it's the questions or comments from the in-person or the virtual, whatever anybody wants. And I'm going to minimize my presentation just so if there's virtual people making facial gestures, I can see. Yes, sir.
Is there an EKG finding that promotes you to do more testing like cardiac echo? Is there, like, let's say we did a pre-op EKG, and sort of like poor airway progression. The person has no history of myocardial infarction, but often I see this poor airway progression. Is that something automatically an echo, or functional status is good, just go for it?
So the question was, are there specific EKG abnormalities that would warrant for further testing, even with a patient without new or worsening symptoms? And the specific EKG abnormality that was brought up was poor R wave progression. So yes, there are absolutely a new left bundle branch block. I would not tell a patient to go through an elective surgery without prior testing for a new left bundle branch block. For poor R wave progression, that can absolutely be a normal variant. It can be pathologic. That's when I'd look more, look for other things. If the patient is undergoing, let's just put it in they're gonna go a left total hip arthroplasty. They surpass 4 METs. They have poor R wave progression on ECG. I would not automatically do preoperative testing based on the poor R wave progression. Poor R wave progression can also be lead placement, a fair amount. If the person's torso habitus gives you a clue that maybe they were not in the perfect Einthoven spots from the 19th century, that for me personally, that may be something where I'd lean towards saying maybe it is an automatically loss of anterior electrical potential. So the answer is yes, there are still some though. A new diagnosis of AFib. Okay, that's a very common thing that we run into. So a patient was going to have, honestly, colonoscopy is probably the most common thing. They're a reasonably healthy 50-year-old going to go through a cancer screening colonoscopy and they show up on the day of in AFib with no prior diagnosis. One, I am happy to see that as a formal preoperative evaluation, and I'm happy to go through the things with them. Because part of it is also going to be assessing what and when do we do antithrombotics with this patient, therapeutic anticoagulation with this patient.
Thank you.
That's an extremely common abnormal EKG thing that we find all the time is a first-time diagnosis of AFib. Thank you. Any other in-person or virtual questions or comments?
Thank you.
I'll defer to the moderators how long of a clock we give them before we
I think you're good. If
give
there's
them
no
back their
questions, I think you're
afternoon.
good. Yes.
Thank you.
Yeah, thank you.
All right.
Dr. Please.
Thank you, everybody.